The topic we're discussing now is respiratory physiology. If you look at the basic concepts in respiratory physio, obviously the physiology section will be covered separately in the physiology part, but I just want to cover that part of respiratory physiology that is relevant in answering questions in medicine. So if you look at the gases, first of all, what gas we are breathing in through the airway, then this is the inspired air, and this inspired air has a partial pressure which we refer to as partial pressure of inspired oxygen. It is referred to as the partial pressure of inspired oxygen. Once it enters the alveoli, then this becomes partial pressure of alveolar oxygen. So you have partial pressure of inspired oxygen, and then you have partial pressure of alveolar oxygen. What gas diffuses across in the blood vessels? This is the partial pressure of arterial oxygen. So we have partial pressure of inspired oxygen, partial pressure of alveolar oxygen, and finally we have partial pressure of arterial oxygen. Obviously there must be a gradient for which the gas is passing through across a pressure gradient from the air into the trachea, bronchioles, and then ultimately into the alveoli, and then it's diffusing across into the artery. So if you look at the formula for partial pressure of inspired oxygen, then partial pressure of inspired oxygen mainly depends on the fraction of oxygen that a person is breathing in, this is known as FiO2, fraction of inspired oxygen, into the atmospheric pressure. But the problem is atmospheric pressure alone is not enough, but because when we are breathing in air, then that air gets humidified, and that has to be subtracted, and this is the reason why we say this is atmospheric pressure minus water vapor pressure. This is known as the partial pressure of inspired oxygen. The question you might be having is, if the person is breathing in air inside the airway, how come then PiO2 and PaO2 are different? Why is it not the same? Because the same air we are sucking inside into the alveoli. If air is coming into the trachea, obviously the same thing is getting pulled into the alveoli. Then why is PiO2 and PaO2 different? The logic here is that when we breathe in, the partial pressure of carbon dioxide which we are breathing in, the fraction of carbon dioxide rather, is almost negligible. Okay, so this is 0.00004, means it's almost negligible. So unlike that, if you look at the fraction of inspired oxygen, it is 0.21. There is 21% oxygen in the atmosphere, whereas the carbon dioxide is 0.04%, which is very, very negligible. So what happens then is when a person is breathing in, the carbon dioxide part of it is very negligible, but once the alveoli is there, then alveoli is constant source of collection of carbon dioxide, and you know that oxygen is entering inside from the alveoli into the artery, and carbon dioxide is continuously coming out. This carbon dioxide is coming out, it's going to occupy its own partial pressure, and this is known as partial pressure of alveolar carbon dioxide. This partial pressure of alveolar carbon dioxide is going to eat up part of the partial pressure, and the important concept to understand is when you add up all the partial pressures at a point, it should be equal to a fixed number. Let me repeat that point again. When you add up all the partial pressures, it should be equal to a fixed number. This law is referred to as the Dalton's law of partial pressures. So what is this Dalton's law of partial pressure state? That when you look at a non-reactive mixture of gases, all the individual partial pressures, when you add up, it's equal to a fixed number. So what you need to understand then is that the partial pressure mixture that is there, when you add up all of them, ultimately it's a fixed number. Generally that's the atmospheric pressure. So in that sense, when you are looking in the atmosphere, what we are breathing in, the partial pressure of carbon dioxide is almost negligible, but once that gas reaches the alveoli, then the carbon dioxide that is constantly coming out is going to occupy a part of the share of the partial pressures, which means because of this Dalton's law, when the PaCO2 starts becoming significant, then obviously the other gases partial pressure should come down. What's interesting is that the partial pressure of nitrogen or the partial pressure of water vapor or the partial pressure of other gases is not affected. Every increase in carbon dioxide in the partial pressure seems to reduce the partial pressure of alveolar oxygen, and this relationship between alveolar oxygen and carbon dioxide is known as an obligatory relationship. What that means is that if carbon dioxide had not come out in the alveoli, then the PiO2 and PaO2 would have been equal. If CO2 was 0, if CO2 would not, carbon dioxide would not have come out, then what is coming in the trachea is the same proportion of gas you would have got inside the alveoli as well. And you can write this in this form, that partial pressure of alveolar oxygen, that means, is differing from PiO2 simply because of the alveolar carbon dioxide. Had alveolar carbon dioxide not been there, then PaO2 and PiO2 would have been equal. Okay, it's the carbon dioxide that is eating up part of the partial pressure. That's the reason why the alveolar oxygen is getting reduced. Partial pressure of alveolar oxygen is reduced. So this is a very simple concept to understand then, that if you are looking at the partial pressure of alveolar oxygen, it's nothing but calculated as FiO2 into atmospheric pressure minus water vapor pressure. Remember, this we discussed is nothing but the PiO2. What I am writing here is PiO2. Problem is, we don't have PaCO2, we don't have alveolar carbon dioxide. We can get arterial carbon dioxide via ABG, but we don't have alveolar carbon dioxide. We can't put a cath inside and take a sample. Obviously, we are measuring arterial and we need to derive what the alveolar carbon dioxide would be. And how we derive this is a simple point, that alveolar carbon dioxide is nothing but arterial carbon dioxide divided by the respiratory quotient. So this is a very basic formula that is important for our exams, and you should try to make an effort to remember this, because there are questions asking about the alveolar arterial oxygen gradient. Why is that alveolar arterial oxygen gradient important and how it is significant in answering questions, I'll tell you later. But before that, you need to know how to calculate the alveolar oxygen. So it's simply the FiO2 into atmospheric pressure minus water vapor pressure. That entire thing, this part of it, is nothing but representing the partial pressure of inspired oxygen. And partial pressure of alveolar carbon dioxide is basically nothing but arterial carbon dioxide divided by respiratory quotient. In a normal person, generally the respiratory quotient we calculate, the respiratory quotient or the R factor which I have written here, this is nothing but the amount of carbon dioxide produced, the volume of carbon dioxide produced to the volume of oxygen consumed every minute. And if you put these values, roughly you will find that it is 0.8, because around, if you take average for carbon dioxide, considering the possibility that the person has proportionate amount of fat and carbohydrate intake in the diet, roughly the consumption factors we are talking about, for every 1 gram of metabolic activity, that is consuming oxygen to burn the energy, how much carbon dioxide is produced. So we calculate respiratory quotient for individual proteins, individual fat, individual carbohydrate, the entire body together we are measuring, and this is the respiratory quotient, is the volume of carbon dioxide produced by the body per minute to the amount of oxygen consumed by the body, and this is roughly around 0.8. This is known as the respiratory quotient. So having understood that PaCO is obtained by arterial gas, this ABG, FiO2 roughly in a person at sea level is 21%, this 0.21. Atmospheric pressure at sea level is 760. The water vapor pressure is around 47. What alters the water vapor pressure is not height above sea level, unlike atmospheric pressure. What alters the water vapor pressure actually is the body temperature. So at a person whose normal temperature doesn't have fever or normal body temperature, generally we expect the water vapor pressure to be around 47. The arterial carbon dioxide in a normal person is around, at rest, is around 40. Okay, breathing normal tidal volume, normal person, you will see roughly around 40 is the carbon dioxide. The respiratory quotient we discussed is 0.8. Instead of 0.8, you can write 1 divided by 0.8 as 1.25. Depends on what you find easier for calculation on the day of the exam. You can choose that. Instead of writing 0.8, you can write into 1.25. Choice is yours. If you calculate this, then we are talking about 0.21 into 713, that is 760 minus 47, and this becomes 50, because 40 into 1.25 roughly is around 50. So if you do this calculation, then this is basically 149.73 minus 50, and we roughly round this up to 150. So 150 minus 50, approximately what you're going to get, the partial pressure of alveolar oxygen is around 100. Okay, this is the partial pressure of alveolar oxygen at rest. So you notice how we got this. Let me go back to the concept once again. When a person is breathing in inspired air, then what air we are breathing in is more of oxygen and very minimal amount of carbon dioxide. It's almost negligible amount of carbon dioxide. We breathe in oxygen and we breathe out carbon dioxide. Dalton's law states that when you add up all the partial pressures, it should be equal to one fixed number, and that fixed number generally is atmospheric pressure. So basically, when a person is breathing in, because oxygen is significant and carbon dioxide is negligible, what we are getting is the PiO2, and PiO2 mainly depends on the fraction of inspired oxygen. FiO2 into atmospheric pressure minus water vapor pressure. Generally, this is the formula we need to use for PiO2. In certain places, we may not consider water vapor pressure simply because the amount of whatever pressure that is there is 47, is very less compared to 760, the atmospheric pressure. Many times you might just manage just by using this as the thing, that is PiO2. Also because whatever pressure doesn't change with height above sea level. So generally what we are focusing on is these two things, FiO2 and atmospheric pressure. However, if the MCQ is giving choices that are more accurate, then better you use whatever pressure to calculate the partial pressure of inspired oxygen. That air that came in negative, when we create a negative pressure in the thorax and the air is getting sucked inside the airway into the alveoli, then that same air obviously enters the alveoli, but then the partial pressure changes now. We don't say PiO2 anymore, we are saying partial pressure of alveolar oxygen. The reason why partial pressure of alveolar oxygen is differing from partial pressure of inspired oxygen is because the constant flow of carbon dioxide coming in it, eating up part of the partial pressure. And for this reason, had carbon dioxide been zero, then these two we are saying are equal. The reason why alveolar oxygen is differing from PiO2 simply because of accumulation of carbon dioxide. So then if you understand this formula, then it's very easy to follow. We just instead of PiO2, I'm using the formula for PiO2. Partial pressure of alveolar oxygen is nothing but FiO2 into atmospheric pressure minus water vapor pressure minus PaCO2 divided by respiratory quotient. And in a normal person, then with respiratory quotient we take it as 0.8. So this 0.21 into 713 minus 50, and this is what it will be. So this is roughly the partial pressure of alveolar oxygen at room air, where a person is breathing in fraction of oxygen, that is 21%. This is generally what the partial pressure of alveolar oxygen will be. You notice then, if a person is giving 100% oxygen instead of 0.21, 21% oxygen, let's say if you make this 1, if you were to make this 1, then the number will change significantly, because then this is going to be 713, because this is going to be 1 if you're giving 100% oxygen, minus 50, that means it is going to be 600 plus, that is going to be the number of the partial pressure of alveolar oxygen in somebody who is getting 100% oxygen. That means the amount of oxygen that is coming inside the alveoli definitely depends on the FiO2. It also depends on the atmospheric pressure. When a person starts going above sea level, the higher the person goes above sea level, the lesser the atmospheric pressure. Remember, the atmospheric pressure at sea level is 760, but imagine if the person goes to 10,000 feet and the atmospheric pressure came down to around 347, then we are saying this is, let's say, I'm just giving you a number, around 347. So 347 minus 47, that means this is going to become 300. 300 into 0.1, obviously the number is going to be significantly less. So it's important to understand then the factors that affect the partial pressure of alveolar oxygen. Also, what does affect the partial pressure of alveolar oxygen is the carbon dioxide. Don't forget, the carbon dioxide and the alveolar oxygen are basically in an obligatory relationship. The more the carbon dioxide there is, the lesser the alveolar oxygen is going to be. Okay, if you just simply analyze this formula, partial pressure of alveolar oxygen is nothing but PiO2 minus PaCO2. That means higher the PaCO2, lower the alveolar oxygen is going to be. We'll understand this concept when we're talking about something called type 2 respiratory failure or a hypoventilation condition. In hypoventilation, if the air is not playing in and out of the airway in the lung, then accumulation of carbon dioxide is going to significantly reduce the partial pressure of alveolar oxygen. The more carbon dioxide builds up in the alveoli, the lesser the partial pressure of alveolar oxygen is going to be. So this is one of the important concepts to understand about hypoventilation. And then again, you need to realize this idea that when a person is hypoxic, if the person's tissues are not getting enough oxygen, one of the immediate countermeasures that will happen is the patient will start having tachypnea and tachycardia, means the respiratory rate is going to go up and the heart rate is going to go up. Basically, the effort of the body is to send faster hemoglobin to the lung so that it can pick up oxygen and deliver it to the tissues. When this is happening, you can understand whenever there is increased respiratory rate, what do you think will happen to the carbon dioxide? When a person is breathing faster, carbon dioxide is getting pushed out faster, and more the respiratory rate, more carbon dioxide is washed out of the body. When patient hyperventilates and carbon dioxide is washed out of the body, naturally the amount of arterial carbon dioxide will decrease and amount of alveolar carbon dioxide also will decrease because most of it has been washed out. If the alveolar carbon dioxide decreases, naturally the immediate benefit that will be there is the alveolar oxygen. So this is one of the ways how the body gets more oxygen inside, is simply by washing out carbon dioxide. As carbon dioxide is washed out, then the partial pressure of alveolar oxygen will increase, thereby allowing better oxygenation. So one simple method to get more oxygen is simply reduce the carbon dioxide. It can do that by increasing the respiratory rate. It's important to understand about the concept of the alveolar arterial oxygen gradient. The partial pressure of alveolar, partial pressure of arterial oxygen gradient. This partial pressure of alveoli, alveolar oxygen minus arterial oxygen helps us in understanding many pathophysios and many diseases, because when we have a patient coming with hypoxia or hypoxemia, then there are only few select conditions how it can happen, and we need to break it down into what exactly is the cause for that hypoxemia. Then this alveolar arterial oxygen gradient is going to be a big help for us, and how it will help I'll just explain in a few minutes. But before this, let's understand this very simple idea that we are going to calculate alveolar oxygen. We obtain arterial oxygen. The partial pressure of arterial oxygen is obtained by arterial blood gas analysis. Okay, this is arterial blood gas analysis will tell us about the partial pressure of arterial oxygen. Using these two, we can get the gradient. First, understand that in a normal person, there is a gradient, and that gradient in a normal person is generally calculated as h plus 4 divided by 4. So, h by 4 plus 4, that is a normal alveolar arterial oxygen gradient. Okay, normal alveolar arterial oxygen gradient. So, what is the normal alveolar arterial oxygen gradient? If a person is 40 years, then is 40 divided by 4, that is 10, plus 4, 14, that is a normal alveolar arterial oxygen gradient. Supposing a person is 20 years, then 20 by 4, that is 5 plus 4, 9, that's the normal alveolar arterial oxygen gradient. You understand then, as the person ages, the alveolar arterial oxygen gradient also is going to increase. Next, I'd like to point out towards one very important idea of something called hypoxia and hypoxemia. They are not the same. When tissue does not get oxygen, this peripheral tissue does not get the oxygen, that's called hypoxia. Any reason, whatever be the reason, maybe it's a hemoglobin problem, maybe it's an oxygen problem, whatever be the issue, if the ultimate tissue that is there in the body doesn't get oxygen, that is called hypoxia. However, hypoxemia is a different concept. Hypoxemia is simply connected with the partial pressure of arterial oxygen. So, simply, if the PO2 levels are low, you can say this is hypoxemia. This is because the dissolved oxygen is more or less connected with the partial pressure of arterial oxygen. So, what do you mean by hypoxemia? Simply is a condition where the dissolved oxygen is low. And what are the conditions where you can have low PO2? And I remind this concept once again to you that low PO2 actually denotes dissolved oxygen, and how dissolved oxygen is connected with PO2 and what's bound oxygen, what's oxygen content, we'll discuss in a few minutes. But I want to finish this idea of what exactly are the causes of hypoxemia. So when you look at the cause of hypoxemia, and I told you hypoxemia simply should give you in your mind that this is nothing but dissolved oxygen, which is represented by the PO2. So when we talk about hypoxemia, there are actually 4 or 5 main causes of hypoxemia. One is, it could be hypoventilation. This can result in low oxygen in the blood. It could be a person with ventilation perfusion mismatch. Okay, this is nothing but ventilation perfusion mismatch. The third is, it can be a shunt phenomena. The last two conditions are extremely rare. A scenario where FiO2 is low is highly unlikely unless the person is in some flight with a cabin pressure that is reduced, or there are various scenarios where, but it's extremely rare for a normal person in the hospital to have a low FiO2. And the fourth and final problem, is diffusion related issues. And again, diffusion related issues are highly unlikely in most of the patients. So these two things, I would say, we don't need to worry much when it comes to decreased PO2 in the blood. The 3 main things I would say to focus on when you see somebody having hypoxemia whose ABG reports are showing the PO2 is very low in the blood, and this patient has got decreased dissolved oxygen in the blood, that means then 3 main things to consider: either it's a hypoventilation, either it's a mismatch problem, or it's a shunt. These 3 are top. Now, how to differentiate among these 3 is simple, that when you look at the alveolar arterial oxygen gradient, partial pressure of alveolar arterial oxygen gradient, this is going to be very, very useful for us in deciding whether the problem is hypoventilation, or it's a mismatch between ventilation and perfusion, or it's a shunt phenomena. If you look at the alveolar arterial oxygen gradient, then remember the concept I just told you, that the partial pressure of alveolar oxygen is definitely inversely related to carbon dioxide. Remember, partial pressure of alveolar oxygen is nothing but partial pressure of inspired oxygen minus partial pressure of carbon dioxide divided by the respiratory quotient. And remember, higher the partial pressure of arterial carbon dioxide, lower the partial pressure of alveolar oxygen. In a patient with hypoventilation, one of the core problems that occurs is the person is breathing less number of times, or there's a blockage, or the patient has got a central disease in which respiratory rate, instead of being between 10 to 20, is now become 2 or 3 times he's breathing per minute. So if a person is breathing 2 or 3 times per minute, then obviously that is significant hypoventilation. Okay, a normal respiratory rate is anywhere between 10 to 20 per minute. So what we are seeing in this case, that means is ki higher the carbon dioxide, because if air comes in and goes out, then only carbon dioxide can go out. But if there is no play of air in, either because of diaphragmatic weakness or chest muscle weakness or a central cause, in whatever be the reason, if alveoli are not inflating and deflating and air is not coming in and going out, then you cannot expect carbon dioxide to go out. Higher carbon dioxide that is built up naturally is going to cause lower alveolar oxygen. If the alveolar oxygen is low, tell me then, if this alveolar oxygen is low, what do you expect the gradient to be? Is it going to be high or low? Because the alveolar oxygen itself is going to be very low. If that's the case, then you might understand, then you cannot expect a high gradient because of a decrease in alveolar oxygen, and this is the reason why the gradient is going to be low. Low in the sense is going to be in the normal range. So what you need to understand that is, higher the carbon dioxide, lesser the gradient. This clearly tells us this patient has got hypoventilation. However, if you find a shunt phenomena, if you find ventilation perfusion mismatch, in these two cases the carbon dioxide is going to escape out. In the carbon dioxide is going to go out naturally, then what will happen is the alveolar oxygen is going to be low. So what you find then is the partial pressure of alveolar oxygen minus partial pressure of arterial oxygen is going to be very high. This is because air is coming inside the alveoli, it's not able to enter into the blood. For this reason, alveolar oxygen is high, but the arterial oxygen is very low. This is going to result in a increased gradient. When you get an increased gradient, the possibilities, it may be a mismatch problem, it's a shunt problem. Both are possible. Whenever you see a very high partial pressure of alveolar oxygen gradient, let's say the partial pressure of alveolar oxygen and arterial oxygen gradient is say above the age allowed. For example, in a 20-year-old person, we expect that 20 by 4 plus 4, that's the formula. So it should be 5 plus 4, 9. That means approximately about 9 or 10, that should be the upper limit of the alveolar arterial oxygen gradient. But let's say the alveolar arterial oxygen gradient actually is 40. The alveolar oxygen is very high, arterial oxygen is very low. If it's 40, that means we are now expecting one of the two possibilities, either it's a mismatch problem or shunt problem. The way to resolve between these two conditions is give 100% oxygen and see. If you notice that the arterial oxygen is improving, if you find arterial oxygen is improving on giving 100% oxygen, then this is clearly a VQ mismatch. But if you give oxygen and there's no benefit to the patient, if the gap doesn't change, then this is simply a shunt phenomena. A shunt is simply giving higher FiO2. As you know, FiO2 is connected with alveolar oxygen. That means higher you increase the alveolar oxygen, you are going to get more gradient, because your arterial oxygen is not going to increase. If you give oxygen and the arterial oxygen fails to rise, then that is a shunt phenomena. So both ventilation perfusion mismatch and shunt, both are going to have alveolar arterial oxygen gradient that is high. The way to differentiate between the two, give oxygen and see. If the patient responds to the 100% oxygen, FiO2 is 1, he responds to 100% oxygen, then that's a mismatch. If it doesn't respond to the oxygen, then there's a shunt. I'll give you a simple example of a shunt. Let's say a patient has got a tetralogy of Fallot. This is an intracardiac shunt, extrapulmonary, out not in the lung. This shunt is in the heart itself. Let's say a patient has got tetralogy of Fallot, and tetralogy of Fallot, the blood that's coming to the right ventricle cannot enter the pulmonary artery because of the infundibular narrowing. That blood, because of the overriding of aorta, enters the aorta. So blood came to right heart, in the right ventricle, doesn't enter the pulmonary circuit, bypasses the lung and enters aorta. Now imagine if 70 to 80% of blood that came to the right heart is not entering the lung but bypassing the lung and entering the aorta, then only about a small fraction of blood that enter the lung, and that blood that enter the lung, there's a limit to how much it can get oxygenated, and how much ever FiO2 increase, you cannot get higher oxygen inside the body. This is because a major chunk of the blood is bypassing the lung. This is simply what is referred to as a shunt. So although this is a very basic example of a shunt, we'll go into more details of how a shunt phenomena occurs and what are the concepts connected with it. I hope you understand then the alveolar arterial oxygen gradient has got a lot of significance for us. When you see somebody having a low PaO2, your first job is to calculate alveolar arterial oxygen gradient. If the gradient is normal, we're talking about hypoventilation. If the gradient is increased, we're talking about two possibilities, either a mismatch, that is ventilation perfusion mismatch, or a shunt phenomena. You give a higher FiO2 and see if the oxygen, arterial oxygen is rising proportionate to as you are increasing alveolar oxygen, then that's a VQ mismatch. If it does not, then we're talking about a shunt phenomena. FiO2 low, diffusion problems are highly unlikely in a person who is in our hospital. Most of the time is generally these three things that we are considering when you see somebody having a hypoxia or a hypoxemia. The next concept one should be aware of is about the oxygen content of blood. Now, if you look at this idea, if you look at oxygen content in 100 ml of blood, roughly we understand about 20% of this more or less is oxygen, because hemoglobin that is there in the blood is oxidized, is got oxygen in it, it's attached to oxygen molecules rather, and this oxygen, if you actually see in 100 ml of blood, roughly around 20 ml is oxygen. How that comes is, we divide the oxygen content of 100 ml of blood into dissolved oxygen plus bound oxygen. Okay, this is dissolved oxygen and bound oxygen. What is dissolved oxygen? Is basically, as I explained to you already, the partial pressure of arterial oxygen gives a good idea about how much is the dissolved oxygen, and this is the formula that we have. It is 0.003 ml per millimeter PaO2 pressure, plus the bound oxygen is 1.34 into hemoglobin into saturation of hemoglobin. So this is a formula that gives us an idea about how much is the dissolved oxygen and how much is the bound oxygen. The important concept to understand in this is that any number, however large the PaO2 be, once you multiply it by 3 decimal points, its value becomes negligible. Whereas when you look at 1.34 into hemoglobin into saturation, however low the hemoglobin, still the bound hemoglobin will be the most important hemoglobin that is present in the blood, that is basically required for transporting blood oxygen from the lungs to the tissues. If I just give you an idea, let's say if you take a PaO2 of even 100, then you can see that if you take the PaO2 to be 100, then 0.003 into 100 plus, let's say the hemoglobin is around 15 and it's completely saturated, that means the saturation factor is 1, in which case you see that this becomes 0.3 ml, whereas this is, so if you do the calculation, this comes roughly to around 20 point something. So you can see this is roughly around 20.3 amount of oxygen that is there in 100 ml of blood. But you notice then how much the fraction that is there in the dissolved state is almost negligible in front of the amount of oxygen that is there in the bound state. So it's important concept to understand that whatever oxygen is picked up at the lung, it is going to be predominantly carried to the tissue in the bound state rather than the dissolved state, because the fraction of oxygen that is there, the amount of oxygen that is there in the dissolved state is basically denoted by the PaO2, but the hemoglobin is a major carrier molecule. But then it's interesting to understand that the amount of oxygen that is bound to hemoglobin actually depends on the dissolved oxygen. How that relationship comes about is, you must have heard about the oxygen dissociation graph. To understand about the oxygen dissociation graph, you need to know about something called the 30-60-60-90 rule. What is the 30-60-60-90 rule is, roughly when the PaO2 is around 30, we have a saturation of around 60. When the PaO2 is around 60, we have a saturation close to 90. So if you draw this oxygen dissociation graph, then it's going to be something like this. And the relationship that I want you to draw your attention about is actually that at a PaO2 of 30, roughly the saturation is 60. Actually, to be precise, it is 57%. Remember, this is in percentage, this is saturation, and this is PaO2. And PaO2, we just give it in millimeter mercury. Whereas if you look at saturation, that is 100%. That means the maximum you can get is 100%, where all the oxygen is completely bound. Okay, this is 100% saturated. And I was telling you at a PaO2 of 60, then the saturation is going to be 90%. Okay, at a PaO2 of 60, the saturation is 90%. However, at a PaO2 of 100, then you will get 100% saturation. Okay, 100% saturation. So this is an important graph to understand about the relationship between the dissolved oxygen and the bound oxygen, because hemoglobin picks up oxygen from the dissolved state only, but how much oxygen is attached to hemoglobin depends roughly on the dissolved oxygen, that is basically given by the PaO2. You notice at a PaO2 of 30, roughly around 57% oxygen is bound to the hemoglobin. At a PaO2 of 60, around 90% of oxygen is bound to hemoglobin. And at a PaO2 of 100, then 100% saturation occurs. One more number, if you can remember, that's good, and that number is important because at a PaO2 of 40, the saturation is roughly around 75%. This number is relevant for us because in general, in a normal person, the venous carbon dioxide, once the tissue picks up the oxygen, when the blood is going back to the heart, to the lung to pick up oxygen again, then the saturation is 75%, and at that point in the venous blood, the PaO2 is around 40. Sometimes when you're trying to do an ABG and sometimes you mistake and you take a wrong sample and it's a venous sample, then you notice the PaO2 will be around 40, and that's what you expect in a venous sample, and that saturation around that time should be around 75%. So you can see over here It's a much better diagram than what I could possibly draw. And I was trying to tell you about the 30-60-60-90 rule. And you can see here that roughly at a PaO2 of 30, the saturation is very close to 60. At a PaO2 of 60, the saturation is very close to 90%. And I was telling you to remember this particular number, PaO2 of 40, the saturation will be 75%. This is important for us because the venous blood PaO2 is around 40. Now, the logic that and the concept that you need to understand is that when you are looking at a blood vessel through which the hemoglobin is passing through, okay, this is a capillary that originated from one of the arterioles, and let's say this is a capillary, and you have the cells that are here waiting to pick up the oxygen. Remember that much of the oxygen that is dissociated into the tissues is via the capillaries. This is because thicker membranes that is there in the arterial circuit, whether the aorta or the artery, they are not able to diffuse oxygen across because of the thick walls that are there. A single lining of layer is required for the oxygen to diffuse through, and that is basically through the capillaries. In fact, the aorta, for its own oxygen needs, it can't pick up from the blood that is flowing through it, but it needs to have its own separate blood supply, and that is the vasa vasorum. So anyway, the point I'm saying here is that the hemoglobin that came here, it has to give tissues to the cells, and ultimately it's going to come in the venules and then continue into the vein. Now, actually, when the hemoglobin is coming here, it's not that the hemoglobin is able to give off all the oxygen to the cells and then becomes empty by the time it comes here, and it's not that the first few cells got the best advantage and picked up the maximum oxygen, and the last few cells that are there are crying for oxygen. Such a scenario does not occur because you can understand the concept that when the hemoglobin is passing through, remember that what is being diffused into the tissue for oxygen requirement is the dissolved oxygen. And as the dissolved oxygen is diffusing in, naturally then what will keep decreasing over here is what? The PO2. And along this point, along this as it goes, the PO2 keeps decreasing. And as the PO2 keeps decreasing, because that is basically correlating with the dissolved oxygen, as the dissolved oxygen is being utilized by the tissue, the oxygen connected to the hemoglobin keeps being released. And this is basically again the same concept, that as the PO2 comes down, okay, as this PO2 starts coming down in the capillary, the oxygen also is going to be released from the hemoglobin. And you can see in a person who's, let's say, sitting and watching TV at home, totally comfortable without any exertion, in this person you will see that roughly around 25% of oxygen was released in his tissues, and about 75% oxygen is still attached to the hemoglobin. And when the hemoglobin is coming back to the lung to pick up its fresh next load of oxygen, it was still having 75% oxygen attached to it, because in the vein the oxygen saturation is 75% and the PO2 in the vein is around 40%. PO2 40, sorry. So the point I'm trying to tell you is that when it is passing through this tissue, look at the reserve of the hemoglobin. It was just able to give 25%. 25% of its oxygen reserve it was giving to the tissue, and when it came back, it is still loaded with oxygen. In fact, 75% of its sites are still attached to oxygen, and that's why we are saying that the saturation of the hemoglobin when it's being coming back to the lung and is the venous blood, it is still 75% saturated. So how much oxygen was it able to release in the tissues? Only about 25% oxygen. So the important concept that means is there is a constant relationship, an important relationship between the dissolved oxygen and the bound oxygen. The major transporter from the lung to the tissue is the bound oxygen. The amount that is pumped through the blood in a dissolved state that reaches the tissue is very negligible. If hemoglobin were not to be there, then we would not be able to fulfill the oxygen requirements of the tissue. This is because the amount that is going through bound state is very high. The amount that is going through the dissolved state is almost negligible. Remember that as the cells start using the dissolved oxygen, then the hemoglobin starts delivering it, and you can notice that as the PO2 starts coming from close to 100 on the arterial side towards the venous side, as it starts coming down towards 40, then hemoglobin starts releasing oxygen. And I was telling you about 25% oxygen is released in a normal state in a patient who is not doing exercise, and 75% oxygen is still attached to it when it goes back to refill once again and come back. Now, here is the important concept. Supposing the patient does need to exert and tissue start needing more oxygen. If the tissue start burning more and need more oxygen, then it's not that the hemoglobin is going to come back still 75% oxygen attached to it, because as the PO2 starts going below 40, because if the dissolved oxygen is consumed by the cell, then the hemoglobin is not going to hold now to 75% oxygen, rather is going to release a bulk of oxygen. Let's say the PO2 started becoming close to 20 or 15 or 16, you notice the amount of oxygen that is released is significantly higher because that means when required, the hemoglobin gives more oxygen. When not required, it doesn't waste the oxygen and it holds it like a reserve. So this is the beauty of the oxygen dissociation graph. So as the PO2 decreases, that means let's say the PO2 we were talking about was 100 over here, it became 40 over here. But let's say when it came here, the PO2 is 10. When the PO2 starts becoming 10, that means tissues started using a lot of dissolved oxygen. Do you think the hemoglobin is still bound to oxygen when it's going back to the lung? No, it's able to deliver more oxygen. And at this time, it's not releasing 25%, but rather it's releasing 70, 80, 90% of oxygen from its attachment sites. So this is the beauty of the oxygen dissociation graph, that when required, the hemoglobin is able to give a lot of oxygen. When it's not required, it doesn't waste the oxygen, it's keeping it like a reserve and is attached to the hemoglobin. Look at this beautiful concept then, that as the tissue starts heating up, why it will heat up? Because it's burning more energy. Like any machine that does more work, it's going to heat up. The body heats up on exertion, and that means the temperature is going to increase. If the temperature is going to increase, or if the tissue is not getting enough oxygen, and anaerobic metabolism starts kicking in and lactate starts coming out, that means the local pH is going to drop. So the pH decreases, the temperature increases. So basically any scenario in which sufficient oxygenation not coming through the hemoglobin, all these are the triggers that activate the 2,3-BPG synthesis, creating a right shift. And as the oxygen dissociation graph shifts towards the right, you notice then that even at a pH of 40, the oxygen that is being released is not 25% anymore. The oxygen that is being released now is close to around 60 or 70 or more than that. So you can realize the advantage of a right shift, that as it shifts towards the right, even at a pH of 40, for example, it's no more 25% oxygen release, much more oxygen is being released, and that is the advantage of a right shift. So you understand, when required, not only the hemoglobin oxygen dissociation graph is so beautifully built in such a way so that it can give better oxygenation. When required, it will undergo right shift, and when required, when right shift occurs, the hemoglobin is able to give even more oxygen to the tissue, making sure that the oxygen requirement is fulfilled. So that means, what are the conditions in which right shift will occur? When the temperature increases, then definitely right shift will occur. When the pH decreases, acidosis, right shift will occur. At this point, I want to highlight this issue, that when we have patients who have respiratory diseases who are found to have acidosis in our hospital, then we should not make an effort to correct the acidosis, because the acidosis is a defense of the body, allowing a right shift to occur and allowing better diffusion of oxygen at the tissue level. If you try to correct the acidosis by giving bicarb correction, then you are causing the oxygen dissociation graph to shift towards the left side, and alkaline pH causes left shift of the oxygen dissociation graph, in which case the hemoglobin continues to attach to hemoglobin and doesn't release it where it's really required, in which case you're actually worsening the oxygenation in the tissues. So this is an important concept, that we don't go about treating acidosis unless it's really severe, and there are some cutoff points which we'll discuss later when you need to correct the acidosis. But in general, especially if there is a respiratory disease causing respiratory acidosis, correcting the acidosis can be counterproductive. So what are the conditions that cause right shift of the oxygen dissociation graph? The right shift to the oxygen dissociation graph is caused by fever, it is caused by acidosis, it is caused by anemia. Naturally, imagine if the hemoglobin percentage is less, the amount of hemoglobin available is that much only, and that has to do the best job it can. And imagine if that hemoglobin, only few are there, let's say, and they are passing through without giving oxygen to the tissue. That such is an illogical thing that's not going to happen in the body. As you know, the human body is built in the most logical and intelligent way. It is the most intelligently functioning system in this universe. So what happens then, as the hemoglobin is passing through, less of it, if it is there, then naturally it has to do more work, it's able to deliver better oxygen to the tissues. So in anemia, you see a right shift. At the same time, the things that cause left shift are alkaline pH will cause a left shift of oxygen dissociation graph, carboxyhemoglobin, methymoglobinemia, hemoglobin F, which we see, we want the fetus to hold more oxygen compared to the mother. So naturally, hemoglobin F has to have higher affinity for oxygen, so that relatively the fetus can trap more oxygen into it rather than allow it to go back out of a black into the mother. So naturally, the hemoglobin F has got higher affinity, so it's going to be left shifted. So these are all important concepts to understand. Then what are the conditions where you see more left shift in oxygen dissociation graph? If the hemoglobin F is high, methymoglobinemia is there, carbon monoxide poisoning is there, alkaline pH is there. These are all conditions where left shift can occur in the oxygen dissociation graph. This important graph that we just discussed here, that is the 30-60-90 rule I was telling you. Two places you will realize this 30-60-60-90 rule is broken, and they are relevant for us in our exams. So what is the significance of this 30-60-60-90 rule and where it is broken? It is not followed in two important places in their MCQs. One is methymoglobinemia and the other is carbon monoxide poisoning. Let's see the concept of what's happening in methymoglobinemia and carbon monoxide poisoning. So what exactly is methymoglobinemia? So if you look at the methymoglobinemia, this is a condition in which the ferrous form of iron, which is actually, if you remember the hematology section, what we discussed, the hemoglobin is formed by globin and heme. The heme contains the iron and the protoporphyrin ring. So what iron is basically utilized for carrying oxygen is the ferrous form, and this ferrous form has the 4 pyrrole rings, that is the protoporphyrin rings that are there, and these 4 protoporphyrin rings are basically held together by the iron molecule, and this is what is the structure that is responsible for transferring oxygen. Now instead of ferrous, if it is ferric, then obviously the ability to pick up oxygen and deliver it becomes quite decreased, and the hemoglobin, that means, is not doing its best function of transferring oxygen. In this case, we say this is basically oxidized state of iron, and in this state it is not performing to its optimal level. This is the methemoglobin. One important clue about methemoglobin is that the blood color is going to change to the chocolatey color and the chocolate brown color, we say. So if you see a chocolate brown color, or if you see cyanosis, these are all things that are suggestive that they are talking about methymoglobinemia. The reason why I am pointing this out is, unlike this, carbon monoxide poisoning will not be described as having cyanosis or chocolate colored blood. Rather, they'll describe about a cherry red blood, which is bright red in color. So they don't mention cyanosis in carbon monoxide poisoning. Generally in our choices, you'll notice methymoglobinemia and carbon monoxide poisoning come together, and you should know how to differentiate them. So again, the concept is, what is actually happening in meth is metamorphosized. Meth is metamorphosized of ferrous into ferric form, and this ferric form, ferric connected pyrrole rings with heme formation. This hemoglobin where ferric is there is basically methymoglobinemia. Now how did it come to be ferric? Naturally, we understood earlier also in the hematology section that the glutathione should be in a reduced state, and we saw, for example, in G6PD deficiency, that without the G6PD enzyme, the HMP shunt will not work. It will not keep the glutathione in the reduced state. If the glutathione is not in the reduced state, any oxidative stressor can convert ferrous to ferric. That means, can G6PD deficiency cause methymoglobinemia? That's one of the causes. What else can cause? Basically, the enzyme, see, normally whenever ferrous converts to ferric, there's a way how the body makes the ferric back to ferrous, and there seems to be a defect over there. And that enzyme that is required to convert ferric back to ferrous is the cytochrome B5 reductase, which basically uses NADH and converts it back to NAD. It basically uses the NADH, forms the NAD, and the NADH that is there is going to help the ferric back towards ferrous. So this is the enzyme that is there, the cytochrome B5 reductase. If there is a defect in this, or some drug is blocking its action, then the ferric cannot be converted to ferrous. And if the ferric cannot be converted to ferrous, then obviously that hemoglobin is called the methemoglobin. Now what we need to do is, obviously in the treatment, get the ferric back to ferrous. One of the ways we are able to achieve that is by using an alternative method by a thing called methylene blue. Methylene blue is used in the treatment of methymoglobinemia. But before we discuss the concept of methylene blue, what are all the things that can cause methymoglobinemia? Let's just run through that. So some of the drugs that are known to cause methymoglobinemia are dapsone, local anesthetics, particularly lidocaine, benzocaine, prilocaine, sulfa drugs, particularly sulfamethoxazole, nitro drugs, and this is nitroglycerin, nitroprusside, or sometimes it can be well water which is rich in nitrate. Okay, so some well water person is drunk, or some pond water which is rich in nitrates, and that also can trigger this kind of problem. Generally, these are the conditions, and I would say the most important of all this is the local anesthetics, because the typical scenario you see in the exams is a person who is in the dental clinic, and local anesthetic was given, and this person's blood started turning chocolatey red or a chocolate brown color, and that kind of scenario which they're describing is very classical for methymoglobinemia. One major clue that comes from the pulse oximeter. In the pulse oximeter, what happens to the oxygen dissociation graph? We just saw the oxygen dissociation graph is going to be something like this. And in patients with methymoglobinemia, the oxygen dissociation graph no doubt shifts to the left, but at the same time, you'll realize that it starts showing a lesser saturation. Okay, remember, this is saturation on this side, and this is PO2. So it does show a left shift, no doubt, but it's important to understand that the saturation is variable depending on what point you're seeing, whether it's a PO2 that is low or a PO2 that is high. And if you see, the saturation continues to remain at 85% even if the PO2 starts becoming high, it doesn't become 100%. This number is very important for us, that if a patient has a higher PO2 and the saturation is stuck at 85%, that's a very important marker to suggest to us that this could be methymoglobinemia. However, at a lower PO2, you notice it is left shifted. At a higher PO2, that means at a lower PO2 it shows higher saturation, but at a higher PO2 it says lesser saturation. Okay, so let me repeat that. Before it crosses over, before this point, actually it is left shifted. So is it showing a higher saturation than allowed at a lower PO2? Yes, but at a higher PO2 it shows lesser saturation. However, if the MCQ asks you is it left shifted or right shifted, then you can observe here it is left shifted, but then it does cross the graph, the normal graph, and then it fixes the saturation at a point, and that generally is 85%. The one big clue that means that you get is that if the PO2 is high in a patient who's getting good oxygenation, that means they're giving him good amount of oxygen, that person's saturation continues to remain 85%. That's a very important clue to suggest to us that maybe this is a patient who's got methymoglobinemia. The other clues I was telling you, although carbon monoxide poisoning also comes with hemoglobin that is basically not functional optimally, not able to transport oxygen to the tissues, and the same problem occurs in methymoglobin, but the two differ in certain senses that will give us an idea whether it is carbon monoxide or whether it is methymoglobin. One clue I told you, cyanosis is never mentioned in carbon monoxide poisoning, whereas it is definitely an important feature of methymoglobinemia. Both can come with headache, both can come with fatigue, both can come with signs of breathlessness and discomfort. This simply because the hemoglobin is not participating in gas transfer in both carbon monoxide poisoning and in methymoglobinemia. The scenario is very important for us. If it's a dental setup, somebody has got a local anesthesia, or somebody is undergoing a bronchoscopic procedure, or some local anesthetic was given, or some nitro drugs was given, or dapsone was given, that background is very classical for a methemoglobin scenario. However, in a carbon monoxide, they'll tell you that the entire family start developing headache and they start feeling lethargy and confused, and that means that the heating environment or the heater that is there in the room, that is leaking carbon monoxide. And in the winters, this is pretty common problem where they're burning some fire in the room, and that is spreading the carbon monoxide and creating the issue. So the scenario that is there will definitely help you decide whether it is methemoglobin or whether it is carbon monoxide poisoning. But remember the point I told you, remember the pulse oximeter showing a saturation of 85%. Since we are discussing methymoglobinemia, and I told you the treatment for methemoglobin is basically methylene blue. One important concept I want to tell you about methylene blue is that you cannot use methylene blue in a patient suspected to have G6PD, because methylene blue actually can cause activation of hemolysis. So as long as G6PD is not an issue and that is not responsible for triggering the methemoglobin formation, then yes, methylene blue can be used in the treatment. So if you look at the hemoglobin, which is containing ferrous, is basically converted to methemoglobin because of some trigger, drug, whatever be the cause. So what I want to show here is that, see, you have methemoglobin, and methemoglobin normally should have been converted back towards the normal hemoglobin by this enzyme called cytochrome B5 reductase. For some reason, if this is not working because of the drug that is inhibiting its action or some other factor that is not allowing it to work, in that case I told you we use methylene blue in the treatment. Methylene blue uses an alternative pathway, and that is nothing but the NADPH methemoglobin reductase. This methemoglobin reductase also is able to convert the methemoglobin back towards the ferrous form, that is hemoglobin. So this is how methylene blue works. It is able to convert the methemoglobin back towards hemoglobin by utilizing this enzyme called the NADPH methemoglobin reductase. That's the mechanism of action of methylene blue. Remember the point I just told you, that we cannot use methylene blue in a patient who's got G6PD deficiency. Simultaneously, we can finish up the concept of carbon monoxide poisoning, and in a person who's got carbon monoxide poisoning, then you do realize that carbon monoxide has got a very high affinity for hemoglobin. Carbon monoxide binds to hemoglobin almost to 25 to 250 times more avidly, and this is a much more stronger bind that is there compared to oxygen. So once the carbon monoxide attaches to hemoglobin, obviously it makes the hemoglobin non-functional. One of the reasons why the carbon monoxide poisoning is far more dangerous than a methymoglobinemia scenario is that carbon monoxide not only creates an issue with the hemoglobin, but it also diffuses into the cells and blocks the electron transport chain, just like cyanide. and by hindering the electron transport chain, it also does not allow dissolved oxygen to be utilized at the cell level or the tissue level. So it's not only a carrying of oxygen scenario disease, there is also carbon monoxide blocking the electron transport chain, and utilization of dissolved oxygen also is getting blocked up. That's one of the reasons why carbon monoxide definitely is far more dangerous than methemoglobin. We have an antidote for methemoglobin, and I showed you that we use methylene blue in the treatment. But when it comes to carbon monoxide poisoning, is very little that we can do apart from removing the source of carbon monoxide and then giving high pressured chamber, hyperbaric oxygen we say. And this is basically people are put in a hyperbaric chamber in which higher partial pressure, atmospheric pressure. We saw the equation already that the partial pressure of alveolar oxygen depends on atmospheric pressure. So if you put a patient in 2 to 3 atmospheric pressures, that is hyperbaric state, then the dissolved oxygen is definitely going to increase. So we are not having hemoglobin to deliver the tissue oxygen to the tissue. We are trying to increase the oxygen by increasing dissolved state, and we can do that by giving hyperbaric oxygen. So what happens in carbon monoxide poisoning then? Again, you notice over here that the oxygen dissociation graph that is there. One important concept to understand about the pulse oximeter is the pulse ox is basically going to read the hemoglobin in the deoxy or oxy state by using two wavelengths. And I'll just tell you about the pulse oxide in a minute. Let's finish off this concept about carbon monoxide. And again, what you're noticing here, that yes, it does cause a left shift initially, and that's what we see. But then the saturation is significantly decreased. The saturation percent far more than what you would expect in a methemoglobin, which was kind of stuck around the 85% scenario. And this saturation is far more lower. But initially, yes, it is left shifted. And in general, what happens is that the pulse oximeter, the SpO2, when you say it is basically pulse oximeter saturation, is going to be far greater than the actual saturation. This is because the pulse oximeter considers, or rather the wavelength which reads the oxyhemoglobin, it mistakes the carbon monoxide bound hemoglobin as oxyhemoglobin, giving it a falsely higher reading. So what exactly is pulse oximeter and what's happening, I'll tell you in a minute, but just remember this concept here, that actual saturations in both methemoglobin and in carbon monoxide poisoning are low. But when you look at the pulse oximeter, why is the pulse oximeter reading higher? Remember, there we saw pulse oximeter is giving a reading of around 85%, that is low. But why is it giving higher over here? This is because the pulse ox, basically the pulse oximetry that we're using, it basically flickers with two important wavelengths, and these two wavelengths are 660 nanometers. Okay, I'm talking about the pulse oximetry now. So at 660 nanometers, it is able to pick up the oxyhemoglobin better. At 940 nanometers, it is able to pick up the oxyhemoglobin. And when you put the pulse oximeter across a thumb or whatever tissue we're using, whether it's the earlobe or the thumb or the fingers, then the two wavelengths that are constantly flickering is basically 660 and 940. The 660 and 940 basically have the deoxyhemoglobin is going to pick up more of the 660, and the oxyhemoglobin is sensitive to the 940. What this means is that once the sensor is picking up the information as the wavelengths are firing, then it is going to pick up how much of light is passing through in the 660 and how much is passing through 940. And based on that, it's able to tell how much is the deoxyhemoglobin and how much is the oxyhemoglobin. By using the saturation is nothing but the oxyhemoglobin divided by the total hemoglobin. And instead of saying total hemoglobin, you can say oxyhemoglobin divided by oxyhemoglobin plus deoxyhemoglobin. This is the saturation. So by finding out how much is basically blocked by the 940 nanometer wavelength and how much is blocked by the 660, the sensor is going to tell how much is the oxyhemoglobin content in the blood and how much is the total hemoglobin, which includes the deoxyhemoglobin, and it calculates the saturation and tells us. So as I was telling you, the issue that is there is that carbon monoxide is basically picked up by the same wavelength as 940, meaning the carbon monoxide bound hemoglobin, is it mistaken as deoxyhemoglobin or oxyhemoglobin? Oxyhemoglobin, and that's why the pulse ox is reading very high, and it gives a high saturation even though the PO2 is kind of low, or even though the actual saturation is low. So this is the issue that we have with carbon monoxide poisoning. So you cannot rely on the pulse oximeter in telling whether the patient has got an oxygen delivery problem, because in carbon monoxide poisoning, the pulse ox is going to read high. If you do the ABG calculates the saturation differently, not the two wavelengths I was telling you, it calculates differently. and definitely when you do ABG and the saturation calculated by the machine there is definitely going to be low. And this is an important concept then, that the pulse oximetry oxygen saturation and the machine calculated via ABG, that saturation, if there's a difference between the two, this is known as a saturation gap. And this important concept then, that whenever you get a saturation gap of more than 5%, that means we are talking about some other hemoglobin that is creating an issue, which could be methymoglobin, which could be carbon oxide hemoglobin, is some other that is creating an issue over here. So let me repeat it once again: pulse oximetry saturation and the saturation calculated by the machine when you do ABG, if there's a gap between the two, then this is known as a saturation gap. It tells us that there is some problem in the pulse ox reading. Consider a possibility that maybe there is something interfering the pulse ox reading. Maybe it's some nail polish, maybe it is a different hemoglobin that is there inside, maybe methemoglobin, maybe carbon oxide bound hemoglobin or carboxyhemoglobin. So these are some important concepts to understand. In a pulse oximeter, what are the two balloons that are firing? I was telling you, just revise once again. 660 nanometer picks up deoxyhemoglobin, 940 nanometer picks up oxyhemoglobin. What's the saturation? The two lights that are flickering, how much is passing through is basically calculated by the sensor. It tells us how much is oxy compared to the oxy and deoxy combined. Based on that, it calculates the saturation. This is known as SpO2 because this is calculated by the pulse oximetry, and this is the SpO2 because this is pulse oximetry saturation. So I hope you understood then. The general concept is, in methemoglobin, the pulse oximetry is going to be lower than the saturations. This is because I told you it is going to be sticking around 85%, whereas in patients who have got carbon monoxide poisoning, generally pulse oximeter is going to be reading higher value because it mistakes carbon monoxide bound hemoglobin as oxyhemoglobin and it gives a higher reading. So this also is another clue that will tell us that this is basically suggestive of carbon monoxide poisoning. The point that means is, if there is a problem in the saturation reading, particularly connected with pulse oximetry, consider possibility of other hemoglobins like methemoglobin and carbon monoxide hemoglobin. So to summarize then, we should know about the relationship between saturation and the PO2. A few more points I want to tell about the concept as I'm discussing the physiology behind all this is in medicine where the relevance comes. That when we are managing patients on ventilators in the ICUs, then in most patients, when we are doing the arterial blood gas analysis, as long as the PO2 is above 60, that's fairly good for us. This is because you can understand when the PO2 is 60, what's the saturation? The saturation must be 90%. That means the hemoglobin is significantly able to carry a large chunk of oxygen to the tissue and is doing a good job. Notice that from 60 all the way up, the benefit is not much, because what will increase when you increase the PO2? The dissolved oxygen will increase. And I told you, whatever be the PO2, the moment you multiply it by 3 decimal points, 0.003 into PO2, the value, however big the PO2, it will decrease. That means dissolved oxygen, as I told you, is not the way how transportation occurs from the lung to the tissues. The oxygen is basically transported via the trucks that are the hemoglobin. Okay, so hemoglobin, if it's carrying oxygen, that's the best way how we can deliver. And I can tell you that when the PO2 is 60, how much is the saturation? 90%, in which case it's carrying a good amount of oxygen and hemoglobin is doing a fairly good job. The point I'm trying to stress here is, when we have patients on ventilators, it may not be the best way to give higher FiO2, because one of the ways how we can increase partial pressure of oxygen, arterial oxygen, is to increase FiO2. Remember the concept that we discussed earlier, that partial pressure of alveolar oxygen depends on FiO2 into atmospheric pressure. Partial pressure depends on FiO2 into atmospheric pressure. Now, higher the FiO2 we can do, higher the alveolar oxygen, higher the arterial oxygen you can get, higher the arterial oxygen, then definitely this will keep on increasing. But then what's the harm with this is, in patients who are on ventilators, patients who have diseases like say ARDS, if you keep giving higher FiO2, 100% oxygen, let's say if you're giving, then in that case the alveolar oxygen is going to be very high, arterial oxygen is going to be very high, but it doesn't give much to the body, because the moment you, as I told you, multiplied by 0.003, 3 decimal points, it value in the content of oxygen actually is going to be negligible. But then the disadvantage is oxygen toxicity. Would you want to give a patient high amount of oxygen toxicity and create more free radical and more injury, when you know that by giving higher FiO2 and getting an arterial dissolved gas above PO2 of 60 may not benefit much, rather it will only increase toxicity. And that's the reason why, when is it that you are interested in giving oxygen to patients? When you find the saturation is less than 90 or the PO2 is less than 60, those are the patients who are going to benefit by giving higher amount of FiO2. We discussed this concept repeatedly in many other places, like in ischemic heart disease. I told you, for all patients with myocardial infarction, we used to routinely give oxygen earlier. Now new guidelines have come up clearly that in MI patient, if the saturation is less than 90%, give them oxygen. If it is saturation above 90%, then it will not create benefit, rather it might be actually harmful by creating more free radical damage. So in most places, then when will you be happy? When you see an ABG showing a PO2 more than 60, or when you see a saturation more than 90%, that's good news for us. That means the oxygen transfer is good. No point in trying to make it 100% saturation, or no point in giving higher FiO2 to increase the dissolved oxygen. You only are going to increase oxygen toxicity.